And we're essentially our own little nonprofit within the School of Social Work at UT. And we do a lot of research, some programming stuff, and some training, which I'll talk about in a second. But our focus is really to seek justice, cultivate intentional connection, and act with integrity. Those are our core values that we work from. We do research and evaluation primarily on child welfare issues, but also on teen pregnancy prevention. So we've evaluated some of the evidence-based curricula that are out there. And then we, from that work, have developed several trainings, and this is one of them that I developed after evaluating several teen pregnancy prevention curricula and trying to understand how to best reach caregivers, because that was a gap, and I think it still is a gap. We also do some program support and strategic planning and curriculum development. And so while I'm talking, I will just say, which I forgot to say, I can see the chat and I can see the question and answers. So please feel free to go ahead and throw stuff out there if you have questions you want me to stop at any time. And I'm happy to do that. The multitasking part is a little new for me on Zoom, but we'll see how it goes. So please, if I don't answer a question, don't feel offended. It's just that I'm not that sophisticated yet with Zoom. So I do want to start by asking you, when I do this training live, sometimes I do it as a 6-hour training and we really get to dive into material. At other times I do it as a 3-hour and then now just a real quick 1-hour training. But I always start with this question. And so I want to see if you guys can indulge me and just type in the chat box on the side. When you're working with youth, what makes you, let me see if this, I want to know what makes you nervous, what makes you scared, and what might make you hopeful when thinking about youth and sexual health. So what makes you nervous, scared, or hopeful? So if you guys don't mind, just type away in the chat box and let's let some things pop up. So we're seeing things like, I'm going to say the wrong thing, their caregivers are going to be mad at me, their attitude, stepping on the toes of people with political and religious beliefs, yes. Say the wrong thing, using the wrong terminology. Okay, thank you. I appreciate all of that. So this, no matter when I've done this training, I get the same answers. And thank you somebody for posting hopeful, that we're trying to make a difference. And then how open youth are to talking about these topics and how resilient and resourceful youth are. So that's wonderful, thank you. I think though we're all scared of the same types of things. We're scared of saying the wrong thing. We're scared of hurting kids because we got into this work to help kids. And so I want to talk through that a little bit today and unpack some of it as much as we can in a short time frame. So today I'm going to talk about a framework and kind of a strategy I've developed to walk people through a new way to think about sexual health with foster youth. So the first step is really understanding. So when I'm talking to sexual health educators, I want to make sure that they understand that trauma impacts behavior. When I'm talking to child welfare workers or caregivers, I want to make sure that they understand that sexual activity is happening. And most of the time they do understand that. It's more caregivers that we have to talk to explain, you know, this is going on, or it may be going on, or that the youth is just thinking about about it and they need someone to talk to. And then I'm going to talk about shifting. So this is the part where I tend to spend the most time, which I won't be able to do today, but shifting from this idea that sex is scary to sex is a normal part of being a human. Because a lot of youth who have experienced trauma already think sex is very scary. And so we've got to kind of shift their thinking, and alongside it, shift a lot of the thinking of our caregivers as well. And then talk about how to engage youth. We're human, so it's okay to be scared. It's okay to think like, I'm not really qualified to talk about this. But it is our responsibility as adults to do so. And so together, that kind of provides us an idea, a framework for thinking about adolescent sexual health. So I'm gonna start with trauma. And I always start with this quote from Maya Angelou: there's no greater agony than bearing an untold story inside you. And the reason I like this quote is I think with trauma, especially with sexual trauma, it's something that we bury and we let other people bury because it's very hard to talk about. But the result is we have youth who have very distorted ideas about what sex is. And we have youth who have those ideas, but no tools and nobody to talk to really process that. So I'm going to start with just talking about trauma. And I think you guys know this based on how many of y'all are out there who are already working with youth. So I'm going to go quickly through this. We know that a high percentage of our population have experienced adverse childhood experiences. We also know that the number of youth who have experienced sexual abuse is likely very much underreported. And that's something, even right now, in the time of us being at home and not knowing what's going on, is really scary to think about how much child abuse may be occurring that we don't know about and that we can't help with. We also know that people experience other sorts of trauma in their household, witnessing family violence, witnessing a family member who is depressed, emotionally disturbed, or suicidal, or a parental incarceration. Sorry, guys. So more important than that, yes, we know people experience trauma, is how our brain responds to trauma. And I think this is really the key piece that I want you to keep in mind. So our brain develops from the bottom up and from the inside out. So essentially the most primitive parts of our brains develop first, and that's our brainstem, which regulates all the information that goes into our brain. So when we're babies and we have those natural responses to things, being scared of things until our mom tells us it's okay, that's part of our process of learning. And until we're comfortable and until we feel safe, we don't engage what we call, in a very simplistic, right, because I'm not a neurobiologist, our upstairs brain. And that's where our cognitive reasoning is, that's where our deeper thinking is. But when we're in a state of trauma, we are using that downstairs part of our brain. And we're not able to think about the consequences of things. We're not able to think about the most appropriate action to things because we are in a survival mode. So when we think about kids who are experiencing developmental trauma, which is trauma from poverty, substance use, parental mental health, and instability, what we're looking at is kids who are constantly in a state of using that downstairs part of their brain. And so that cognitive skill set that they need to survive in the world is not developing in the way it should. That does not mean that those kids can never develop those skills. It just means that we can't expect them to process trauma and reactions the same way that someone who hasn't experienced that would. Chronic trauma is living in a war zone, ongoing sexual abuse, family violence. Those are all examples of chronic trauma. And then the acute trauma are things that happen just 1 or 2 times. Oftentimes you see youth who have experienced sexual abuse early in life, also experience sexual assault later in life. And those are both acute traumas, but they're impacting that person. And so the trauma itself is not as important as the response to trauma. So right now, I would say 100% of us in America are experiencing trauma, but we're all reacting to it differently. We're all a little scared, we've all got anxiety, but for people who have already experienced trauma in the past, that's heightened and elevated in terms of their response, because they're going back to that downstairs part of their brain a lot faster than the rest of us who may or may not have experienced poverty or food instability in the same way. So another way to look at this is complex trauma. So a lot of the kids we work with in foster care in particular who have experienced trauma have experienced all of these: developmental trauma, chronic, and acute. So we just call it complex trauma. And then what we see throughout generations are cycles of trauma. So we've got family members who experience developmental trauma and now they are parenting and unsure of how to parent, or unsure of how to deal with their own emotions while they're parenting, and that creates additional trauma. So what does this look like with sexual abuse? So all types of abuse, I want to be clear, can impact the way kids look at relationships and look at sex and sexual health. But what we see most and what we think of most is sexual abuse. And because it is so underreported, oftentimes I would find as a social worker that I was working with a kid who had come into foster care for physical abuse, but in reality, in their history, the more I got to know them, the more I would see, like, yeah, there are definitely signs of sexual abuse, but it takes a while for people to kind of disclose that and really talk about that. So one thing, and I wish I could see your faces to ask you guys about this, but we see with older youth in particular, this idea of reestablishing control. So a lot of times I wish I could have you all raise your hands for this. If you're working with, let's say, a teenager who gets into a relationship with somebody much older than them, and everybody kind of scratches their heads and goes, why is she in that relationship with this person who's so much older than her? This is exactly what happened to her as a child, this person controlling her. But it might actually be a way of her reestablishing or trying to reestablish that control that she had lost. We also see eating disturbances with folks. And one of the stories I like to tell is with the ACEs study, what was so interesting about that is the research began with a doctor who actually was studying obesity. And he said, when I had a chance to talk to him, I asked, like, how did you come up with this? Where did this come from? And it's Dr. Folletti, and he said, you know, I was running a clinic and we helped all these people lose weight. And then I kind of stepped back and I realized that there were a lot of people who just weren't as happy as I thought they would be. And he said that one lady in particular just kind of, you know, during a group looked down and said, but now people see me. And she was very uncomfortable with her body because of everything that had happened before. And so to him, that was a trigger to go down a path of, well, what's happening, right? Why are people having eating disturbances that might be related to something else? We also see youth who are less able to see risk, and they have very blurred boundaries that create that risk. So even with little kids, you might see kids who are very quick to attach to others, very quick to sit on somebody's lap or give them a hug. And we see that with older kids where they get in relationships and they're not quite able to see the red flags in that relationship. And we also see self-destructive behaviors, self-abuse, like cutting, or that feeling of wanting to be invisible. So the kid with the hoodie over their head. And that's kind of the coping mechanism, is just having people not see them, or being in relationships that mirror abuse. And then oftentimes when there is a relationship, there may be a lack of mutuality or a lack of, even in very healthy relationships, feeling like there's only, the pleasure is for somebody else, never for the person. And so those are things people have to work through, and they're real things that as we see youth get older and we want them to be in healthy relationships and we want them to be fulfilled and be parents, if that's what they want, that we have to be able to talk to them about. So for foster youth, when we're looking at sexual health and why this is so risky, we see first that there are changes in caregivers. So a lot of us are in Texas or in states surrounding Texas where there are a lot of very conservative values, and people believe that this is the responsibility of a child's parents. And that's fine, but with foster youth, there are so many changes in caregivers that you see that people are not stepping up and taking responsibility for having conversations. They just assume somebody else did it. So I know for me, that would result in working with girls who were getting their first periods and had no idea what that was. And that should not happen to anybody. We also see that youth change schools. So what sex education they could get in school, and in Texas, that's really spotty. They change schools so often, they're likely to miss that. And then we see there's a lack of access to sexual health care. So even if you can get to a health clinic, most youths are going to have trouble navigating what permissions they need, who they need to talk to, or how to ask a foster parent to take them to a clinic. And then we also see a lack of therapeutic relationships, because I feel like a lot of people think that, well, you know, maybe a caregiver can't manage that conversation, but a therapist can. But again, youth move so much that there's not that mental health connection that there would be with a counselor in a normal setting where a kid develops that rapport with a therapist where they really trust them. And what we've seen from older youth and some of the research I've done is that they didn't feel like they had anybody they could trust until they were well over 18 and on their own. So let's see. So another question I always try to pause and ask is, and if y'all don't mind putting in the chat also, so what messages do you receive about sex right now? And what messages did you receive as a young person? And I'm just gonna pause for a minute while you guys. So it's bad and wrong, they should be embarrassed about it. Dangerous, shame, it's no big deal, bad. Yes, very private, shouldn't be discussed. Yes, thank you guys. One of the things that I always find when I ask this is there's always two people in the room who will raise their hand and say, nope, my parents did a great job. And I'm always really excited about that, but I'm like, that's usually just one or two people out of 100, and that's just not good. So most of us didn't receive great messages, but we want to be able to provide better messaging. So one of the messages that I think most people receive is this, and this is from Mean Girls, the movie. But it's the coach telling everybody, don't have sex because you will get pregnant and die. And usually it gets a good laugh from people because they're like, yeah, that's pretty much what I was taught. And we want to really believe that we're teaching something different. But when you really look into sexual health curricula and you kind of look at the messaging that's in there, this message, while not as blatant as you see here, is in there. It's hey, if you have sex and get pregnant, it's your fault because you knew what to do. Or if you have sex and get an STI, that's on you. You're responsible for your behavior. And while that may be true, my argument is if you are a child who's been sexually abused, that wasn't your fault. And if you get pregnant as a result of that abuse, that is not your fault. Or an STI, that is not your fault. So I think we're sending a message then to kids who have been sexually abused that they need to not talk about it. And I think that's really dangerous. So we want to shift. And we want to talk about sexual health. And we want to recognize that it's not just one conversation. This whole idea of the birds and the bees and you sit your kids down and you just lay it all out for them isn't going to work. Because it needs to be an ongoing conversation, which is why it's everybody's responsibility. Because if we have youth who have experienced trauma who are being raised by a grandparent or somebody else, they need to take responsibility for whatever point that child is in their life and talk to them. So I've gone through and I just have this broken down into pretty broad categories for today. But in working with young children, some of the things that we want to make sure that we do. So we want to make sure that we're labeling body parts and that we're giving them the correct name, and you don't have to worry about whether or not you're exactly correct with terminology, but I do think it is important. Like, you don't look at your elbow and say, this is my arm corner, right? So why call a penis a peepee? Kids need to know what that body part is, and when we put cute names on things, we tend to minimize, or send a message that there's something different about this body part. And we don't want to do that. We want to make sure kids know how to label their body parts. And one of the major things with that is we want them to be able to tell us if somebody touches that body part inappropriately. So even pediatricians will often start labeling those body parts at well checks. So kids are aware, and they're aware that nobody touches them there. We also want to work with young children about boundaries. And this doesn't have to be anything to do with sex. It can be just my space, my physical space. And making sure that they know that somebody else's body is their body, and that we don't touch, we don't give hugs unless somebody says that they want a hug, and make sure we start to instill that in people. So just some phrases that people can use. I put down here. We keep some parts of our body, like our bottom and our penis, covered. They're private. Only you, mommy, daddy, your doctor can help you with those parts. And then another one. This is my body, and I don't want to be touched there. So give them the language to say that. And then working with school children. So we want to explain reproduction. And I do believe this really strongly. I think by the time kids are kinder, first, second, they're already hearing things that are a little bit like, what? So it's best if somebody just goes ahead and explains just the basics to them. So a baby begins when a penis enters the vagina and sperm comes out. Sperm then goes inside the uterus and meets with an egg. There are a lot of books out there that actually have pictures. And I will admit to you, it is completely uncomfortable to be the one who has to give that basic lesson. In my family, it's always in me. But it is really important. And I find that using a book and going through it once with a child and then letting them digest it, going through a couple days later, answering questions, and then you just keep the conversation going. Definitely want to explain puberty. There's absolutely no reason. I just feel like it's a basic human right that every child should know what changes are happening to their body. Sorry about that. So you want to explain puberty. You also want to explain what sex is. And so one way that I worked with folks to explain sex, because we want to make sure that people understand that sex is not just something between male and female, right? So sex is something that can happen in different ways. It usually means bodies are close and together, and people are kissing each other because it feels good. And so we want to be able to kind of make sure that kids know that. And so this is just kind of an aside from the story, but recently my first grader had a dog jump on her, and she loves dogs, and the dog was like licking her all over her face, and she told the dog, stop kissing me because I'm not going to marry you. And so it was just an interesting and a great opportunity to talk to her about what kissing was, and what sex, and then that led into a good conversation about what sex was. So we also at this age want to reinforce privacy and boundaries. And then in working with adolescents, we want to listen. I think adults are very good at telling adolescents what to do based on our own personal experiences, but we want to make sure that we stop talking and that we let them talk to see where they're at. We want to reserve our judgment and try to coach them by asking them questions. So when do you think would be the right time for you to become a parent? And focus on their strengths. And also just admit that you're nervous. I think adults are nervous a lot of the times because they aren't sure how to explain things like sex. Honestly, I get a little nervous. I'm going to say the wrong thing, but I want to at least try to make sure you have all the information you need. So go ahead and admit what your limitations are. A lot of us were raised in Texas where we got very little sex education. And so unless you're in the health field or a health educator, you might really lack a lot of information. That's okay. So I want to finish with you're human. You can have these conversations. They will be hard. You will need to take a deep breath before you have them, but you can do it. So we talk a lot about reframing people's narrative when they have experienced particularly sexual abuse. I put some phrases up here that you can use in your work. Because when I started doing this, I was like, yeah, you want to say something like this? And people kept asking me, what exactly do I say word for word? And so here are just a couple examples. So sex can be a healthy thing when everyone involved consents or chooses to take part. Other times it can be harmful, like when one person is forced by another or raped. Sometimes people have sex in order to survive. Sometimes people feel pressured to have sex. And then you want to make sure that you're always emphasizing that no matter how you've experienced sex in the past, that you can have a healthy sexuality and sex life and try to give some power back to them. Another way that we talk about doing that is by using the SAMHSA's guidelines for a trauma-informed approach. And I'm going to go kind of fast through these so I can take questions. But the first idea is that you have to feel safe. In order to trust somebody, in order to talk to somebody, you've got to feel safe. So thinking about talking to an adolescent in particular, you want to make sure that you know what your own attitudes and values are and you minimize your judgment. using LGBTQ inclusive language, particularly when you don't know where a youth is coming from, is very important. You want to avoid scare tactics. So a lot of what I heard in working in the foster care field was people would say things to youth like, oh, and some of you guys posted this, you know, boys just want one thing. Well, that's not actually true. Or, you know, just stay away, you're going to get pregnant, it's going to ruin your life. That's also not true. I have a lot of teen parents in my family who were great parents, and it did not ruin their lives. It made it a little bit more difficult for a while, but it didn't ruin their lives. So you want to operate also from a sex positive perspective, making sure that instead of those scare tactics, you're talking about, hey, sex can be a really wonderful part of your life when you're ready for it and if you choose it. And then always talking about choice and consent and making sure we're moving from the, well, he or she didn't say no to the yes means yes idea. You want to be transparent. So answer questions truthfully as you can. Provide age-appropriate information and normalize behaviors. So it's okay to feel that way, or it's okay to be thinking that, you know, and then pivot to, well, let's talk about how we can get you like accurate information. So I know for me, I'm not up to date on all the medical information, but I know how to teach somebody what websites to go to look for that, or what websites not to go to look for that, or how to coach somebody into asking a doctor how to talk about those things. And be very clear about confidentiality and reporting. If you're going to have to report something, I think you have to be really upfront so that you don't lose that trustworthiness. Peer mentors and peer support are great. And when that isn't possible, looking for books, movies that could stimulate conversation and using the discussion points in those to talk and to just kind of listen. And this, I think, is really hard for grown-ups. So recognize that the youth is the expert on their own life, and you're not there to control them, which is hard, which is why you listen more than you talk, and realize that youth are not going to see you as an equal in that relationship, because you're as an adult, you have some power that's different from them. There's a differential power dynamic that's happening. And so it's really important to kind of acknowledge that, and acknowledge that they also have choice, though, as to what they do. And you're just there to help provide information and help them think through those choices. Traumatized youth are likely not going to see you as being able to understand their experiences. Probably a lot of you who have worked with youth have, over time, you'll see that a youth may give you bits and pieces of their story, and they continue to do that over time. And it's almost a way to test to see how much can you actually handle, how much can I actually tell you without you panicking about it. And that doesn't mean that you disclose everything that's happened to you. And so that's really important too. That disclosure can really signal that you're not going to be able to understand their experiences, because the experiences of each individual is their own, and they're very different. So we focus on strengths. We encourage you to think about the future, to ask for opinions, and we really avoid those short statements that probably all of us grew up with, like, just wait till you're married, or just don't do that. We also want to make sure that we encourage youth to develop their own voice in the healthcare system. They need to learn how to have discussions with medical providers And I think for all of us working with youth, particularly in foster care, it's our job to try to mirror that and model that so that we can get them ready to have those conversations. And again, discussing consent and choice. And then the last thing that's part of that framework is to acknowledge the impact of social and economic inequality. You want to consider young people's choices within the context of their lived experience, which is not your experience, it is theirs. Even if you're the same race, ethnicity as a youth, even if you had similar experiences at the same age, it doesn't matter. That youth's experiences are their own. They're living in a different time than you, they're living in a different, just everything in you. So a lot of times adults like to do that, well, when I was younger, this is how I did things. And it's okay to share that, but it's not okay to assume that what you went through is the same as what they went through. Another thing that we want to make sure that we don't do is demean their family. And unfortunately, I heard this quite a bit, phrases like, don't you want to be better than your mom? Don't you want to be there for your child, not like your father was for you? Those are definitely a no. Every child that I've met who's experienced trauma, even if it's the person who caused them that trauma, there's still some connection, there's still some affection for that person, and so that they're working through. And so we want to make sure that we don't demean their family, but rather we try to help them find strengths in their family that they can build off of as they make choices about their future. All right, so I am going to stop there because I know I was talking really fast at the end. I wanted to leave time for questions, but also to see, just to kind of get you talking about what some of the barriers are for taking this back to your work. And somebody was asking me, what is the soy technique? And that slide might have gotten taken out. But it's just a technique to use when talking to youth. It's some people believe this, other people believe this, you get to decide. So when you do have different values and you're unsure about people's values and where they're coming from, and I use this with my kids a lot, like, because right now I've got neighbors who are definitely not social distancing. So, some people believe social distancing is very important right now, like our family. Other people don't feel as strongly about it. You get to decide what you think. And it's just a real quick reminder, present both sides, especially when it's not, your own child that you're talking about your family's beliefs. Make sure you leave it open for them. Yes. So some of the barriers are those of you who work in school districts teaching comprehensive sex education. Yes, it is. It is a challenge. So that's always going to be a barrier, I think, in some of the states we work in, especially with younger kids. And so I think the boundaries, though, go beyond comprehensive sex ed, and it's really about safety. But again, sometimes that doesn't even work for people. And then another Monica was asking, like, using the soy technique, even if it's not fact-based. I think you're talking about beliefs, right? So you can say, some people believe this, others believe this. Here's what, you can just add in there. Here's what I know based on science or whatever. And then what do you think? So sex ed for individuals with intellectual and developmental disabilities. We actually have an expert on that at UT Austin, and I can send her your name. Send her name out. I need to find it and give you that contact information. But I think that is really critical, and I'm not an expert on that area, but she is. And I think that that's, yeah, we need to talk more about that as well. Oh, and actually the campaign has a webinar about that, so they'll provide that to you. Let me just scroll through. Like I said, I'm not super sophisticated about technology, trying to make sure that I've gotten all the questions answered. All right, so in the chat, are there any other barriers that you might foresee in taking this back to your work? Oh, yeah. So from a clinic perspective, a barrier is that adolescents enter appointments with their guardians and doctors do not ask them to stay outside so teens can have privacy. Yeah, I think that that's interesting. I think there's also some education to do with parents about that. I know for, just as a parent myself, I've got a 12, 13-year-old on their next well-child visit, and I was trying to think to myself, when do I send her in by myself? So I actually don't even know. But if there were posters or something that emphasized, hey, you know, let your doctor talk with your child alone for part of the visit. That might be important, or a way to work around that. Another barrier, talking about abortion as a viable option. Yes. Yeah, we live in Texas. I don't know what to say about that point. It's really hard, but I will also say that in my experience, when I was working with foster youth who were learning about their pregnancy, abortion was almost never an option that they considered. They obviously knew about it, but they also didn't consider adoption as an option either. So I think in a lot of cases what I saw was foster youth who are pregnant would really look at that pregnancy as an entry into adulthood. And even though it wasn't something they planned, it was something that they wanted and embraced. And so I'm not saying that we shouldn't provide all options. I'm just saying it wasn't like the foremost thing on their mind as it might be for us. And then lack of inclusivity. Yes, values of some facilitators reduce the use of inclusivity. I'm wondering if that's referring to LGBTQ youth. I think that facilitators have to really start to shift their language and change how they're thinking, and in some cases even be willing to be retrained almost. I would say 4 or 5 years ago, when we would present on this topic, it was really hard to figure out how to talk about sex without using male and female, especially for younger kids. But we figured it out. And I think that it's some work and it takes some practice, but we can train facilitators better, I think. And I think the campaign is actually a really great resource to do that. So sex and Christianity. Oh, that could be another webinar, couldn't it? So I will say one of the things that I've done quite a bit is train foster parents in this training. And I've done it in very rural areas of the state. And I remember the first time I went to a very rural area, I was just thinking to myself, they're going to yell at me. I was going to a church, actually, because it was a foster parent group that met in a church. And I thought they're going to kick me out. I don't even know what. But I talked to them and we practiced saying different things. And when I left, I remember this woman who didn't speak at all just like grabbed my wrist and said, "You're going to come back, right? You're going to come talk to us again." And it really kind of opened my eyes to the fact that like everybody struggles with this. And I don't think it is, I don't think it's in opposition to Christian beliefs to talk about healthy sexuality. And so I think it's just the reframing of it. And foster parents in particular, and kids who have worked with foster youth, because they see youth that have sometimes highly sexualized behaviors, they're often confused about how to deal with that. So they're a little bit more open to, how do I talk to this kid? How do I deal with this? But other than that, I think if I went farther, we would have to just be here for another hour. Yeah. Any other barriers? And your funders being uncomfortable is something. So yes, I think, so can you talk about issues that arise when sex ed curricula don't acknowledge LGBTQ youth? Yes, I absolutely can. I will say in one of the pregnancy prevention curricula that I evaluated, a lot of the examples that were in that curricula were boy-girl. So they had youth doing role plays where there was a boy and there was a girl, and it was very heteronormative. And a lot of youth were just like, this doesn't apply to me. I don't know, this just doesn't apply to me. These people don't care about me. Why am I in here? And so I think we lose kids when we don't acknowledge that. And the other part of this is that youth today, I'm even seeing it in my middle schooler, they're so much farther ahead of adults in talking about these things that this is already part of their conversation in many cases, not in all, but in many cases. And so it's important that we include that in curricula and that we make sure we're talking about that as well, because we don't want to lose kids. And we see that LGBTQ youth are kids who oftentimes, because of the discrimination that they face, have higher rates of suicidality, self-harm, etc. All right, any more questions? Let me see. I want to give you guys a chance because I've been told that I don't allow enough time for pauses to let people respond. But I know these slides will be made available by the campaign, so you'll be able to access them later as well. So I think we'll go ahead and finish up. And I'm going to let Melanie go ahead and jump back in and give you some reminders about evaluation and that sort of thing. But I do want to say thank you so much for joining. And if you have thoughts or questions after, please let me know.
Wonderful, wonderful. I'd like to echo what Dr. Faulkner just said, and thanks everyone for joining us today. And also thank you so much, Dr. Faulkner, for taking the time out to share your expertise with us. And just a quick reminder, once you close out, a survey will pop up. We ask that you please take that to let us know what you thought. And we will also send the survey out, the slide deck and a video of this session as well for the folks who want to watch it again or who actually couldn't join us. So anyway, thanks again. We hope you guys all have a great rest of your week.